Let me go. Yeah. Okay, it's Paul Pepe. This is the gathering of the Eagles, the jurisdictional medical directors for the most of the largest cities in the United States, plus some of their counterparts over, particularly in Europe, such as our friend here from Paris, and also many others who join in with us for these discussions. And remember, this is all recorded, goes out publicly, and keep that in mind as we go through here today. But again, at the same time, this is us, this is our meeting, and we just like to share it with the world for those who are interested. Okay. All right, well then let's go ahead and start with Amal Mattu. Amal, you're going to do like an EKG thing or some other cardiologically oriented?
Yeah, I have a bit of a literature update on a STEMI related topic. That the U.S. guidelines, North American guidelines, have been changed since 2013. Europe's way ahead of us. They updated their guidelines in 2017, and my hope is that they're going to be incorporating some of the new literature that has come out. So I'm just going to share the screen real quick. Let's see, and this pertains to posterior STEMI. This is something that we all know should go to the cath lab, and yet the literature has consistently shown that this is the most frequently missed and delayed diagnosed type of STEMI. In fact, only 30% of posterior STEMIs get to the cath lab within 90 minutes. That's what the CARDS literature has shown, and these obviously are associated with the higher morbidity and mortality.
Can I ask you a question real quick?
Yeah, go ahead.
I just want to make sure that because most of the cases do get seen with inferior lateral things or whatever, but there's, in terms of they're about what 10%, maybe 20% of the cases they're isolated posteriors. And are you talking about isolated posteriors here? That's all I wanted to clear up.
No, great point, Paul. So the vast majority of the time when the posterior wall is involved, it is in association with an inferior STEMI, and we're pretty good about picking up inferior STEMI. So when somebody has an inferior posterior STEMI, no problem, because people will pick up the inferior and send them to the cath lab. Right. But the studies say about 4 to 5% of all STEMIs are isolated posterior. Yeah. And so that's a lot of STEMIs. 1 out of every 20 to 25 STEMIs are often missed because the left circumflex, which is the most common vessel involved with these, is they say electrocardiographically silent. That's not exactly true, but it's just not producing the STET in the STEMI that we typically look for. And what we've been teaching for years is that when you see ST depression in the anterior septal leads V1, V2, V3, then you should think about the possibility of a posterior infarction. And what should you do? You get posterior leads. And if the posterior leads show any ST segment elevation of at least a 0.5 millimeter, then you're good to go. The problem is that studies continually show that in the pre-hospital arena and in the ED and in the hospital, posterior leads are very rarely obtained, even though it's really not much of a hassle. And take a look at this. This is a patient who comes in with really just ST depression in V1, V2, V3. And so you might think, well, is this anterior ischemia? No big deal. Just treat them with antianginals. Or this could be a posterior STEMI. How do you tell the difference? Well, simple. Just do some posterior leads. Put 2 or 3 leads in the left mid-back area. And if you see at least a 0.5 millimeter of elevation, you just diagnosed a posterior STEMI. This needs to go to the cath lab right now. 2 o'clock in the morning, you're activating the cath lab. But a lot of people don't get those posterior leads. And so they look at this and they just think, oh, it's just an anterior wall ischemia. And these patients have a worse outcome. Yeah, go ahead.
Now, so one of the things is there if you go back to the EKG, the one you had before, is there a clue that the T wave is up right there, or is that a soft call?
Well, a couple of clues. Number one, there's ST depression. Number two, there's upright T waves, but that it can sometimes be a bit of a soft call.
Okay.
So we can't always rely on the upright T waves. Now, if you wait long enough, then you'll see these R waves get taller. And so I guess that's one thing you could do, just let them sit there and continue infarcting for a few hours, and then you get a tall R wave and you've got your diagnosis. But we don't want to wait hours while they're infarcting.
And V5 and V6 are not showing anything. So
okay. Yeah, those lateral leads don't really help out. Well, this is a very nice study that got published in December of 2021 by Pendle Myers and some other colleagues up at Hennepin. And taking into account the fact that people are just not consistently getting posterior leads, they found that if you just look at the standard 12 lead and the patient has has ST depression in the anterior leads, but the lead that has the most ST depression is V1 through 4, any of those leads, then that is very much diagnostic of a posterior STEMI. So just to recap this, if a patient comes in with concerning signs and symptoms and they have no other obvious reason for ST depression, for example, right bundles usually give you ST depression in the anteroseptal leads, hypo-K, right ventricular hypertrophy. So if somebody does not have any of those other obvious reasons for ST depression in the anteroseptal leads, and they have concerning symptoms, if the lead with the maximum amount of ST depression is V1, 2, 3, or 4, any one of those, it had a 97% likelihood of ruling in for an occlusive MI or an acute coronary occlusion. So if we just look at some now a couple limitations, this is an early study, 118 patients, 2 medical centers, but the study was very, very nicely done. And the posterior lead data really backs up what these authors are saying. So take a look at this. It would be very easy for this to be misdiagnosed as anterior ischemia, and your computer will probably call this anterior ischemia. But notice that the lead that has the most ST depression is, we'll say V3. So it's V1, 2, 3, or 4. Then this is 97% likely to rule in for an acute coronary occlusion involving generally the left circumflex. This is a posterior STEMI. If you don't believe it, you can get your posterior leads. And these were all posterior leads. And you can see that there's ST elevation of at least a 0.5 millimeter out there. Here's another nice example. It doesn't have to be fairly prominent either. You take a look at this. Here's a patient coming in with chest pain, and there's slight ST depression in the anteroseptal leads, but the lead that has the most ST depression is V3. And so that by itself gives you a 97% likelihood that this certainly did turn out to be a left circumflex occlusion. Here's a pre-hospital case that was sent to me by a paramedic in London. And this is a 57-year-old guy with ST depression. The computer is not really calling this a posterior STEMI, but the paramedic looked at this and said, well, the ST depression is anteroseptal. The lead with the most ST depression is V3 again. He did do posterior leads, just if you don't believe it. There's your posterior lead. So this really nails your diagnosis of a posterior STEMI. And this patient goes to the cath lab and had 100% left circ lesion. And here's just one more case. There's many, many cases, but I'll just show you a few of them. This is a subtle case again, 62-year-old chest pain going to the shoulders. And there's nothing in the inferior leads to really help you out, but you see ST depression in your anterior leads. And the lead that has the most ST depression is probably V3 or V4 again. And so purely based on that, Dr. Richards here activated the cath lab, and this turned out to be 100% left circumflex occlusion, even without needing to do the posterior leads. So again, very nice study. It's a first study, but it backs up what a lot of people have been looking at with the posterior lead data. And it would suggest that you probably don't even need the posterior leads if the lead that has the maximum depression is V1, 2, 3, or 4, then that is enormously predictive that you're looking at an acute posterior MI involving probably the left circumflex. And again, this 97% likelihood that they're gonna end up ruling in. Now, I still like doing posterior leads, but they quoted some incredible number saying that out of I don't know, 500 cases, only about 15 had posterior leads. And so if people aren't doing posterior leads, I think you can largely take this study and use it hopefully to get these patients to the cath lab. We'll have to see how more data comes out. The Europeans have already incorporated recommendations in their STEMI guidelines to say, in the European Society of Cardiology guidelines, that if you have ST depression in your anterior leads with posterior lead ST elevation, that those patients need to go for cath right now, but that has not yet been incorporated into the US guidelines. And hopefully this is going to help with that.
Hey, Almo, this is Ray Fowler.
Hey, Ray.
We see so many ST depression cases anteriorly, some of which are quite subtle, like the cases that you presented. I wonder what the specificity is on that. Are there a lot of false positives, I wonder?
There's not actually. I guess I didn't put the specificity in, but the specificity was quite good also. Yeah, I mean, the numbers were really fantastic. Now, I'll bet that a lot of those ST depression cases that you're looking at may have had maximum depression in V5 or V6, in which case that does point a little bit more towards ischemia. But if it's V1, V2, V3, or V4, then that really, really does point towards a posterior STEMI. And if there's any doubt, then I say just go ahead, get your posterior leads, and that'll really nail it.
Does the situation of LVH with repolarization abnormality change your thoughts about this?
No, because LVH usually gives you a little bit of ST elevation in V1, 2, and V3. And usually that strain pattern, the ST depression that you get from strain with LVH is usually maximum in the lateral leads, V5, V6. So LVH should not change it.
Exactly.
If you don't mind, one more quick follow-up. I'm sorry.
Sure.
Are the, I bet you too have been impressed over the years with the improving interpretation, like the electronic interpretation by the EKG monitors, especially in the field. Do you think the EKG monitors will also pick this up?
Well, if it's programmed into the monitors, I think it will. But again, it all depends on the program that's put into those monitors. And if they're not programmed to specifically recognize the leads with maximum ST depression as being most significant when they're V1 through V4, the monitors aren't going to pick it up. Currently, as I understand it, the monitors and the electronic programs that I've seen will only diagnose a posterior STEMI when there's already really tall R waves. But tall R waves, which are analogous to Q waves in the back of the heart, tall R waves take at least 3 or 4 hours or more to show up. So if this is a person presenting in the first couple of hours, you're not going to see tall R waves, and invariably the monitors will not call it a posterior STEMI.
Thanks, Amal.
Great job again. And by the way, as a practical matter, if anybody's going to do the leads, usually what I'll do is first put 8 right underneath the tip of the scapula, and then I surround them with 7 and 9, just as a practical point about where to place them. Would you do anything different, Amo? Is that what you do?
No, that's exactly what I do. I like doing those posterior leads still until I see more data. I'm still doing posterior leads, but again, if people don't do the posterior leads, then this is really good stuff.
As you saw, the readouts sometimes show that it's saying something else. That's why you need to follow up on it. So yeah, that's a good. Thanks. As usual, great job. I think, Glenn, is that you coming through on the 516 number?
Hey, how are you? Hi, everybody.
Yeah. So tell us a little bit about what happened this morning in New York, if you don't mind. Thank you, Amal. This has been great, and please stand by as long as you can. All right. Thanks. Okay. Glenn, what can you tell us at this point in time?
Yeah. Good morning. Good afternoon, everybody. Earlier this morning, just past 8 o'clock, we got reports of a shooting in our subway system in Brooklyn. Then it became multiple people shot at 2 different platform stations, most likely on the train is what we were being told. So we're on scene here. We've got 2 different sites that we're trying to manage. We have 17 patients at the moment that EMS has evaluated. I know this is recorded, so please don't quote me on the numbers, as things are changing all the time. But,
right.
10 of those victims have been shot, transported to 4 trauma centers in this area, and a couple went to surgery. We have not been told of anyone who has been killed so far. We were also told that the shooter fled on a northbound train, so we're all kind of on pins and needles waiting for this guy to pop up somewhere else. We've had multiple calls of things, but they're all hoaxes so far, and we're monitoring. We're standing by still here at 2 locations in Brooklyn and just monitoring the rest of the city to see what's going on.
So one of the difficulties was that he's hard to identify. Was he wearing a gas mask or something like that? I can't remember what it was.
Yeah, the reports were that there was some kind of facial device, possibly wearing some kind of construction uniform with some kind of a package in his hand. It sounds like it might have been a toolbox. So seemingly dressed as a worker, construction or otherwise, is the initial report we're getting. But PD's still investigating everything, and they're looking at some packages and things, trying to clear them to make sure that they're safe.
So was it pretty random shooting, or are things you seeing chest shots, head shots, or what were you seeing?
There are multiple different locations, and it's so far we can't figure this out yet. And I know PD's investigating.
All right, when you said you had two scenes, is there one is on the subway and one is elsewhere or on the platform, or what were you?
Yeah, it looked like one on the platform, and then ultimately on the subway. And as the train moved, people fled. There are quite a few that were trampled as well. And then, always the walking wounded types, green tag, very anxious, understandably. We're also getting reports now of 911 being called to other patients who are distant from this location, as always, who said they were on the subway and felt they needed to go to the hospital now. Those people weren't shot, but we're trying to see if they're related to this incident. And then obviously the walking wounded that fled to the closest hospital, we're not sure of that count, but we'll try to get it ultimately. We only know of the patients that we actually evaluated and either transported or had them refused.
So you've already brought up some great points that I was already going to make. But one of the things I was going to have, I don't know how long you can stay on, I was going to have Pierre Carli comment about this, because exactly in these scenes, what you guys were thinking is just this an isolated thing. And as time goes on, it makes you feel better that's an isolated thing. But it still could be one thing happening here and there's a accomplice elsewhere doing this, or it's a distractor to pull everybody out where you do something really bad elsewhere. And that was part of your plan as well, correct? If I remember.
Yeah, that is. And, as an active shooter for us, our counterterrorism entry teams, we went down to extract the patients. So we got that in place as well. Luckily we don't have to use it often, but it's usually in place, ready to go.
Yeah. Okay. And then of course there's the follow up with the people who are on the train and others in terms of their PTSD stuff that'll come up and so on. Pierre, do you want to comment on this, because you've had to deal with things? A classic was the Bataclan got a lot of notification, but it really was a distractor, and also the Boulevard shootings were a distractor for what they were really trying to do up at the stadium, right?
Yes, exactly. Paul, this is the worst situation as possible. Rush hours, active shooter, panic in the crowd, and for minutes and sometimes hours, the possibility to have several site, a multi-site, multimodal attack. That's what we fear in big city when there is one active shooter. It's not only one, it may be others. And if I understand at the timing, there is no oversight, so it's a good news. But indeed, a shooter in the middle of the crowd, unprotected, with very difficult access in the subway to the police forces, is the possibility of mass casualties and a lot of people killed. So we don't have details, but as soon as we heard about that, we were extremely concerned in Paris, because for us, it reminds us the November 2015 terrorist attack, and it's something that can happen everywhere in the world. So clearly, Paul, we hope that everything will go for the New York EMS as good as possible, and it's always a very, very, very tense and difficult situation.
Yeah. So I may have both of you come on and do presentations on this, just as you said, for our main meeting when we get down there, Fort Lauderdale this year. Anything else you can add then, Pierre? But I was right in terms of the two things that everybody focused on were the people who were attacked in the Bataclan or along the boulevard was really a distractor for what was going to be going on at the stadium, where they were going to try to bomb where there was heads of state and all that. Is that correct?
Yeah. In Paris, it was coordinated. It was very difficult. At the time being, we have only limited information. The fact now is we improve a lot the sharing of operational information at the first minute of a thing like that. So that was the problem in Paris, because we keep on the plan. The plan said, do not go to the first site, do not send all your teams to the first site, because there may be others that will happen in the next minute. And in Paris, we have waited for 20 minutes without sending all the teams available to the stadium because we were afraid of something in the city. And in fact, few minutes after the first shooting, and when we received notification of these shootings, it was 10 to 20 minutes from the first victim in the stadium. So you see, it's exactly what can happen in New York. And I remind you, it has the same problem in Belgium, in Brussels, terrorist attack at the airport first, and then in the subway, and in 2 different places, the subway.
Yep, exactly. So good. Thanks a lot then, Pierre, because you had such experience with this. I really appreciate your thing. But one of the things that we also have to keep in mind is that this event happened in New York, but also I remember very well, and Ray Fowler will corroborate this for me, is that when the first plane went into the building, and I was very suspicious of it because they were just showing how it was a nice day, that the thing went straight into the building. I said, I'm really concerned that this may be a bad thing because that reason. And secondly, is that it may be a distractor for a lot of other things. And it wasn't just that city, it was also Washington, D.C. that was a target there as well. So another thing to keep in mind, that's why we all need to know about this stuff. If it happens in one place, it may happen elsewhere as well. And then you've seen that as well sometimes over in Europe. So, okay. Anybody have any questions?
Unfortunately.
Yeah, Glenn, anything else you could comment after we said that? All the things we just said?
No, absolutely. Please stay safe, everybody. This looks like an individual, not multiple shooters at this point, but we'll be monitoring throughout the day. The city's on alert now to make sure that we can monitor this.
Yeah, and then we're going to talk a little bit. Hopefully, I'm going to have some people on the call here talk a little bit about the MSOC meetings that you guys had. That's similar to the top off. So if you can stay on if you like. If you have to go, we understand too. We're just so privileged to have you on with us at this point in time.
No, thank you. I do have to go, but please stay safe, everybody. Thanks so much.
All right, Glenn. Thanks for checking in.
All right, thank you. Okay,
bye.
Bye.
So, hey, Josh, do you want to comment on this? Because you and I talked earlier this morning about this. Josh Hartman.
Yeah, the only thing to add that I think that the doc didn't cover was that it seems that and again, this is all preliminary, but it seems that the perpetrator had some sort of gas canister with him, and he let the gas canister go inside the car and then began shooting while the train was moving from station 1 to station 2. And so that, he had a mask on, whether that helped him or not. And then there were 4 devices, I think, that Glenn did mention that they found were inert. But a lot going on, multiple things but they do think it's a single bad actor who is currently on the loose, and they're kind of just waiting to see where he pops up. But yeah, just the fact that there were multiple types of attack that he did between the gas canister that was released as well as the shooting. That was kind of the only thing I didn't hear him mention.
Let me clarify this. When you say a gas can, you're talking about a typical gasoline can that someone might
Okay. No, it's described at this point as some sort of gas grenade. I don't know exactly what the substance was, but not petrol. Correct.
That's what I was trying to get at. Okay. And then the IAD.
The IEDs. Yeah. So far, nothing. I mean, at least as of the Fidney's report just recently, nothing to be, they were all reviewed by the bomb squad and there was nothing to them.
Okay. Got it. Well, thanks for that report. Anybody else have anything to contribute into this discussion before we go to the next one? Oh, before we do, Sandy, do you have to get out? Sandy Schneider, do you have to get off at 11?
No, I don't. And really, I have nothing. I'll just put something in the chat.
Okay, great. Thanks, Sandy. I just want to make sure we always had you plugged in here. So it's been a good discussion so far. So thank you. All right. So with that, then, by the way, who's area code? I see an area code, or I don't know if it's area code, but it says number is 5 is the thing, or 516122. Who's that? I'll send you. I just need to know who's on. I'll send a message to that number right now. Then, okay. So, just to find out who it is. All righty. Anybody else want to contribute into that discussion before we move on? If not, maybe I can get a quick. Where I want to get a quick tip or maybe discussion, since I got Eileen here for a little while and John Jew. Let's talk about a little bit about the new variant that's popping up, XE, and then move over to Mark Escott and talk about that we're looking at an endemic kind of phase that I think we've all been sort of talking about that the last couple of weeks. I'd like to have a little bit more of a formal discussion for Mark about that. Are you okay time-wise, Mark, if we do it that way?
Yes, sir.
Okay, good. So let's move on. First, John, you want to give us a report? There isn't a whole lot to tell us yet, but there are reports, particularly out of Thailand and UK, that it sounds like there's a marriage possibly of the Omicron, versions, and that they're calling it, I think, currently XE. And tell us a little bit about that.
Yeah, Paul, can you hear me okay?
Yes,
That's
sir.
all. Okay, I'm going to probably present 4 slides here.
Okay.
Let me know when you can see the slides here.
It just says yeah, there you go. We're on
Okay.
XE variant. You got it.
Yeah, so they're basically, I've been watching this, and Eileen probably knows much more than I do because I'm not plugged into the international scene.
Mhm.
But I've been following this as well. And first of all, as we all know, Omicron, COVID is an RNA virus and has a predilection for recombination. It's a really sloppy virus as well because it's an RNA virus and has recombinations. This is to be expected. The XE variant is a combination of BA1 and BA2, but it has 3 unique mutations to that, which is the cause for concern here as well. And it's being followed by WHO as well as CDC. And we're up to about 650, 700 cases identified in the world, and probably a lot more than that right now. It's thought to be 10% more infectious than even Omicron, which is the real reason for concern. But the symptoms are very similar to BA1 and BA2, as you can sort of see: sore throat, GI, and as well as skin irritation here as well. For me, I'm more worried about XD than XE as well because of Delta and the BA1 variant here as well. And there's a lot of controversy regarding how viable it is in the milieu of Omicron, BA1 and BA2 here as well. But I think we just need to know that these variants are being tracked, and there's currently 3 variant, and the one I'm worried about, I don't know what Eileen is worried, is the XD variant here as well. So far, there's no evidence of any increasing virulence, but obviously there's only 600 to 800 that have been described in the world so far. Interesting enough, and I don't really know the pathophysiology, most of it's been described, obviously UK, and I'm pretty surprised Denmark hasn't identified, but it's identified in Thailand, New Zealand, and probably so Southeast Asia here as well, which is sort of interesting in the way it's being followed here as well. So that's what I do really know. But again, I'm more worried about XD and the recombination of Omicron and Delta.
Okay. And Eileen, anything else you can add to that? Or disagree with? Dr. Marty? She's probably driving in her car somewhere, right?
Oh, I was on mute. That
Okay.
was it. I was talking away, but I was on mute.
Yeah.
Okay.
We play
I'm
things.
sorry. No,
we
no.
play things-
John's fantastic. So I think to help put it in perspective, there is an XE, F, there's a G, K, L, M, N, P, Q, R. So there's a lot of these sub-variants of Omicron that have been defined. And John mentioned XD, which is a Delta Omicron recombinant, first reported, I think, in France and Denmark. There's also the XF and the XS are also Delta Omicron recombinants with that recombine differently, which is really interesting. So, it just goes to show how amazing nature is. And then most of the other X's, right, are either BA1 with BA2 or BA 1.1 with BA2. And John's spot on. So far, there has been no significant differences in how disease manifests with the different subvariants, all these X's, with the exception of XE having that 10% advantage over BA2 that WHO is tracking very carefully. Yes, and I agree with you too, John. I am more worried about the Delta Omicron recombinants, but we obviously have to keep our eye on XE. Plus, we have to bear in mind that everything we're seeing now is in the context of a recent massive surge from BA1, right? From the original Omicron surge, which means we have a certain background of immunity in our populations, particularly here in the United States. And so when you look at that, you go, okay, so right now, since we know that BA1 confers some levels of protection against BA2 and probably against most of the X's, right? But we also know that immunity wanes, both natural immunity and immunity from vaccination. So as long as this thing keeps circulating and immunity continues to wane, there's going to be that point where things start to get really bad. And we're already seeing a gain in cases in some parts of the United States, especially in the Northeast, that isn't yet reflected in a significant rise in hospitalizations. And that goes back to, we had this recent huge surge. We have 65% of our eligible population vaccinated, and we have better outpatient management protocols so that we can keep people from ending up in the hospital.
Yep.
How long that's going to last, not sure.
Yeah.
I would add to Eileen's excellent summary of where we are with BA2, that I've been watching the sewer wastewater more than actually the incident cases. So obviously, because there's so much home testing, we're going to be underreporting of our outbreak. But the sewer wastewater, as well as the hospitalization, is my key parameters I'm watching for our EMS system as well.
And they
I
seem
agree
not to be dramatically increased right now, for now anyways, correct?
Ours predict in Portland, we're going up as
Okay.
well. So I think you can, that's a pretty good predictor of the obviously seroprevalence of BA2 in the community. They'll
Okay.
tell you,
We're
obviously.
going up here too, by the way.
Yeah, we are. So we're at around, we were down to 1.5, 1.2% seropositive in our testing. We're up to 3 to 4% right now in Portland as
Yeah.
of yesterday.
And yeah, and so I don't know who else is testing it that's out there. I know Dave always does it. He's not on right now. Maybe we can hear from Libby, but I think it's going to end up being, I think what we're going to hear is that it's may have moved through some places, but then it's going to pick up in others. Yeah, so you may see it around the United States being such a large country that we may see it spread around. Okay, Peter, you had a question? Peter Antevi?
Yeah, I just wanted to get the opinion. You know, we're seeing what's happening in China now, where they had a no COVID policy and now they're getting slammed. And I wonder if the fact that their population was not exposed to COVID, are we seeing something different there than we would see here in America?
Peter, that's such an important question. And you have to bear in mind that they didn't have the level of campaign that we did in getting people 65 and over vaccinated. And that's part of the problem that we're seeing in Shanghai. John, do you want to add to that?
Yeah, I actually think that that's absolutely true. Hong Kong is really a sentinel event where I would say only about 40% of their older population over 65 was vaccinated, and they got killed. The second thing I want to sort of say is the following, that in my opinion, that the no COVID basically theme is it's outdated. You're not going to stop Omicron as well. If you breathe air, you're going to get it here as well. And the third one is that most of the Chinese have been vaccinated with one of the 3 Sinovac vaccines, and that's clearly inferior to the mRNA vaccine. Would you agree with that, Eileen?
100%. There's no question that those inactivated vaccines are not as good, and definitely not as good against the variants.
Yes.
Okay.
So they're wide open, and they have problems.
Peter, you still had your hand up. You still have a question or another one? Okay.
Yeah, so Peter, the bottom line and what John's saying is so important is that don't mistake, since there's so many different variables, you can't just hang on, oh gosh, they had lockdown and then all of a sudden they have a problem. No, it's super, super contagious and they didn't properly prepare their population in terms of immunity.
Yeah.
Awesome. Thank you, guys.
Yeah. And Peter, by any chance, did you ever do a follow-up yourself on your, you never got a fourth shot, right?
No, I didn't, but my whole family got COVID. I never had symptoms, but they did, and I'm at 100%. So I think my exposure after 3 doses bumped me back up again.
So, last week, I gave the report about the neutralizing antibodies to the group and said, how it was starting to, that I'd gone from a age appropriate 68% myself after dose 2. And it fell off. And then when I got the third dose, it went up to 99% and hung in there for quite a while, then started tipping down. So I did get a fourth shot, and within 2 weeks, I was at 100%. So we'll see if that stays the same way. Again, this is just a surrogate variable for the rest of the immune system. Doesn't mean I'm going to be protected, but it means I probably have relatively better protection. And we'll just have to see, what comes of that. And I had no symptomatology or problems after that. So,
and Paul, just so you know what we're doing next week, we're doing 3 days of antibody testing for the entire city of Coral Springs for the employees.
Mhm.
We're hoping to get 600 people done over a
Mhm.
3-day period. So I'll have some reporting back, maybe not next week, but the week after.
You'll have data about if they got vaccines and when they got it and all that kind of thing, right? So,
Correct.
okay,
Yes,
that
sir.
would be
Yeah.
good. And we'll look at age, sex, and all those kinds of things. It'd be really good to see if there's any differentiation. So, but the thing about age is really profound. It really is interesting that, we kind of knew that, but it was profound in the stuff that we did. All right, so this was a great setup for Mark Escott. So Mark has been our medical director there in Austin and Travis County. And but he also had to sit in and fill in and took over as health director also for Austin during the height of the storm. So it's really great privilege, and it was an eye-opening experience for him. So he's got some opinions now, particularly as a fellow EMSer, to talk about his experience and what he's thinking is happening here. So I thought it'd be a nice thing to bring him in at this point in time. So thank you, Mark, for joining us.
You bet. Thanks, Paul, and thanks, John and Eileen, for the excellent setup for this talk. I'm going to initiate with a little background on how we got to our planning process, because it's relevant to the situation. So early on in the pandemic, this is back in the spring of 2020, we, like everybody else, were looking at a bunch of different data points, trying to sort out how we gain situational awareness. At the time, a lot of jurisdictions were looking at hospitalizations to determine what's happening with the pandemic now. But we looked at this data, and this is, the gray is the hospital beds, heads and beds being utilized. The blue is new admissions to the hospital. The orange is discharges. And what we found is the number of heads and beds didn't reflect well on the activity of the disease. And that new admissions to the hospital was more reflective of the patterns that we were seeing in the community. And we took that information to our neighbors at the University of Texas at Austin, who had an existing pandemic surveillance program oriented to the flu, but a world-class program, and asked them to track this data. This is what our graphs of hospital admission data look like, with the yellow being the 7-day moving average, which we oriented for that modeling, that predictive modeling that was utilized. So once sorry, I thought there was a question. Once UT plugged that information in, along with mobility data from cell phones, we generated a staged alerting system for Austin and Travis County. And the reason that we did the stage alert system is because the question early on was, what strategy are you looking for? Do we do an elimination strategy, or do we do something else? We certainly felt that an elimination strategy for us was not feasible, given that it's Texas, and trying to keep people, ultimately for elimination, we're looking at, basically 9 months of lockdown, which was not realistic. So we oriented that to an oscillation approach, and basically trying to become more restrictive as cases rose and less restrictive as cases fell, to create an oscillation between 0 and our maximum capacity for our healthcare system. So again, important is reducing restrictions on the way down. We identified our hospital threshold, heads and beds, at about 600, our ICU threshold about 200. I've put this as a static line, but I think we've all realized that the threshold keeps dropping as our personnel do as well. But obviously, part of the dialogue now is this waning immunity, both from natural infection as well as from immunization. And when we look at some of the data for prevention of urgent care / ER visits, about 87-90% at 2 months, around 66% at 4 months, and about 30% at 5 months and beyond. For hospitalizations after vaccination, 91% at 2 months, protective, 78% at 4 months. The data on natural infection is still being generated, but somewhere around the 8 to 12 month mark seems reasonable. So with that data, our model team, and we have a collaborative effort between University of Texas as well as Northwestern. These models were generated by a professor named Dave Morton, who's a member of the MIDAS network for pandemic modeling. But this assumes an 8-month waning period for immunity. So what we're seeing here, sorry, I've got to move my thing so I can see what I'm talking about. And what we're seeing here in the yellow and the blue is correlating with our yellow being our level 3 or stage 3, and blue being stage 2. So the assumption for the more restrictive stage is reduction by 68% in transmission. Blue is reduction in transmission by 55%. So what we're looking here on this slide and the next slide is what happens when we drop restrictions on various dates, and how does that affect the model. In this model, the line that's surrounded by the gray is actual cases and predicted cases. The purple line that you see is the waning immunity, the individuals who have waned immunity and are vulnerable to infection. So what we see here is moving the date of downgrading restrictions from March the 12th to April 30th basically serves to feed the number of individuals who are vulnerable to significant disease. So hospitalization, in this circumstance, ICU admission. On the next slide, we see that even more pronounced as we move out to May 31st or June 30th with enormous peaks by waiting longer to reduce restrictions. Again, what the evidence is showing us, and certainly what the model is showing us, is that we need to use a fire EMS term, we need to have a controlled burn of cases so that we have that constantly renewing fresh immunity along with fresh booster administration to reduce that burden of vulnerable individuals. And this is the policy that we haven't really seen said out loud yet. We're certainly, we've seen some federal government policy associated or working along these lines. Nobody has said out loud that this is the reason why we're doing it, at least to my knowledge. But this is what the community needs to understand, that we need transmission of disease at lower levels, controllable levels, along with refreshed immunity to avoid these peaks. We've been playing this game a quarter at a time. And what we need is a long-term strategy to avoid these peaks and troughs that are going to lead to this continued surge effect.
Mark, I got to weigh in here. First of all, there's no faulting the logic that you're providing, except for this long COVID. So that's the fly in the ointment or the fly or the fly in the soup that just makes it very untasty, right? And adds a level of danger. That's why I prefer to keep boosting, maybe having shifts in the exact sequence of nucleic acids in the vaccine, as opposed to it's cheaper to have a controlled burn of cases, but in the long run, it's much more expensive if you consider long COVID.
And Eileen, I don't disagree with you. The strategy is the same. I agree. The preference is renewed immunity via booster, but we're at a point in our country where it's going to be very, very difficult to maintain this vigilance before people are going to lose all health trust in public health. They don't care about long COVID. They want to take the chances.
Well, especially the young ones. Yeah, especially the young ones. Yeah.
I will have to probably weigh in here. I agree with both of you actually. Number one, some of the population, especially one political declination, won't do any kind of vaccination. So it's going to be a law of diminishing returns. But I actually think that our long COVID we're only seeing a tip of the iceberg right now. And I have a lot of respect for long COVID as well. And the third one is I'm not sure how Eileen feels about it, but I think vaccination will get better as far as the coverage. And again, the purpose of the vaccination is to prevent serious disease, including long COVID and mortality and morbidity. It is not to prevent the acquisition of disease. As I said, pediatricians, they get infected all the time. So they're naturally born immunity here as well. And so far, our pediatricians seem to be cognitively fine right now. At least I think they are as well. So I think the issue here is what we want to protect rather than the actual type of immunity. Back to you.
Yeah, John, and I agree. What we've been seeing since December of 2020 is that as cases go up, so do vaccinations, right? Because all of a sudden it's relevant, and maybe I should get it because I know somebody who has COVID. So we've closely matched immunity through disease and immunity through vaccine. So they're traveling together.
Yes.
If we're going to be successful, those have to be separated so that we have immunity and at a different, from disease, separated from immunity from booster vaccines, so that we can create that mix that we need to, manufacture an endemic stage.
So Mark, I love what you're saying, and I'm going to add to it in this way. If you think about diseases that have been around for hundreds of years, right? In essence, right? You normally weed out people, who die from it, and then the people who remain, right, have some level of immunity, and and some people have more or less severe disease. And I'm just very, very generally talking about these things. So now that this thing is no longer new to humanity, right? There are more and more people that have some level of protection, and as long as you have, it's kind of like thinking about it in terms of before there was a vaccine for varicella, older individuals didn't need Shingrix as much as they do now because we had a constant low-level re-exposure, right? That kept us from manifesting shingles, right? So I see the logic in that, as long as we're talking about people who already have some level of protection, right? So you keep that low-level exposure and these little controlled burns among people who are not likely to end up with long COVID, which, by the way, goes to Peter's question on the chat. He was asking about mixing and matching vaccines. This mixing and matching is ultimately a good thing. It gives you better protection. And I will say that my almost 84-year-old mother just got her 4th vaccine and switched from her 3 previous Pfizers to Moderna, and got the most potent reaction she's ever had to vaccination, which is not unexpected. And I sort of warned her that might happen.
Yeah. Let me get another perspective. Well, Mark, go ahead and pop in, but I want to get Libby Char. Be prepared, Libby. I'm going to call you. I want to see what a health director is saying about this. Okay, so
just we've been having this conversation here a lot too, and I kind of I very much understand where Mark is coming from, and I'm kind of in the same spot where we all as individuals and the population as individuals have their own risk acceptance profile. And some are willing to accept more risk than others. Some are willing to accept the risk of long COVID. And I think that the dynamic has shifted from, things like wearing masks to protect other people who are not vaccinated to, if you're worried, wear a mask. But I don't think that we're going to be able to maintain this level of alertness in society, frankly, any longer. And I think we need to sort of shift our thinking to protect people protecting themselves and people accepting their own level of risk.
But one more thing, Mark, and that is, if you have a cold, if you have a respiratory illness, you should wear a mask. We absolutely, but you didn't say that. I mean, I know you know it, but the thing is, we have to say that too. We have to make sure that people don't think that it's perfectly okay to cough, in the middle of a conference, on everybody else, or sneeze or what have you. They should be wearing it.
Eileen,
I know, but that's not as good as a mask.
But you're right. There are some clear policies that should change for the long term.
Right.
Wear a mask when you're sick. When you're sick, you stay home. You don't go to school. You don't go to church.
Right.
You should stay home. That's your responsibility. But one of the challenges that we've had with public policy throughout this pandemic is we all understand that the public doesn't like nuanced messages. So we've stayed away from nuanced messages. But the fact is, the public needs nuanced messages. They need to understand that we're going to paint in broad strokes for the community, but for you, it's with a fine brush. And that's dependent on your level of risk acceptance, your personal health conditions, and your consultation with your family and your physician. We've got to get to that point. We can't dumb it down for people, because that's where the criticism comes from. We didn't nuance it, and now there's a revolt because we didn't.
I could not agree with you more, and I've been fighting that from the get-go. I work with, I'm handled by these media people. And at first they wouldn't let me say SARS-CoV-2. You have to say COVID all the time. I said, but that's technically wrong. I'm not gonna do it, because I think ultimately, I never spoke down to my children when I was raising them. I didn't do baby talk. I didn't think that that was appropriate or good. And the results were excellent. And I do the same for my students. I don't speak down to them. I lift them up. And I think that's what we need to do for the public. We lift them up. Thank you, Mark, for saying that.
When you say media people, are you talking about at your university versus? Yeah, that's what I figured. That's the one. Yeah,
I think we've all been handled.
Yeah, and I sort of I figured out a way to get unhandled. But another thing, though, I'll say a middle ground there with you. I agree with you. I'll use the big terms, but then I'll explain them sometimes if I am giving a soundbite, meaning ventricular fibrillation, a sudden short circuiting of the heart's electrical system, something like that they can relate to. I do want to go over and talk to Libby and just getting. By the way, before I go there, I'm getting reporting from some of my let's see, on the ground contacts there. That it now sounds like there's about 16 people that were shot. 5 were probably critical, but so far stable. Some are in surgery, but it looks like some of the wounds look like shrapnel. So I don't know what it has to do with the weapon or whatever it might be. So we'll have to see if it's related to some kind of explosive thing or whatever that happened. So just evolving there. Terrible stuff. Dan, let's see, by the way, and because they had such an increase in cases in Philadelphia, they've gone back to indoor masking again there. Crawford wanted me to let you guys know that. Let me see that may have been an email from him, but maybe just as an FYI. Libby, tell us about your health director for a state, an island nation, right? So tell us how you want to approach this or what your thinking is.
And so we've been pushing really hard on our messaging to try and normalize things like staying home when you're sick. that's one of the biggest stories that we keep hearing is that people are sick and they had symptoms and they showed up for work anyway. And that's happening in my employees in the Department of Health. It drives me nuts. So we're just trying to normalize things like that, like, you know, that getting boosted is a normal thing and staying home when you're sick is a normal thing. And so we're trying to write that into our transition plan right now to push that message. We're doing pretty well with vaccination. We're also seeing our rates go up a little bit on our case counts. And I'm kind of concerned because our percent test positivity is going up a little bit, even as we're doing less testing. And so I'm worried that it's going to be like, you know, the frog in the boiling water kind of situation, that it goes up gradually. And so people just kind of keep letting it rise. So interesting to hear the conversations now, you know, maybe I shouldn't worry about it so much and let it go. But that long COVID is always in the background that's what I'm worried about.
Yeah. Okay. Thank you for those amphibious remarks. I really appreciate that. So, all right. Well, good. How are you doing? How's everything out there today? Otherwise, okay. Is it a beautiful day in paradise?
Beautiful day, good
Okay.
weather, sunny, good beaches.
Okay, we definitely have to have an Eagles meeting out there, I think, right? Everybody gets a thumbs up for that one. All right, well, good. So let's move on and see if there's let's see what are the other topics I want to cover. Oh, Kasia, are you on? That's not a bad idea. I know you're back in the United States, but you're probably still in contact with people over there. Anything new happening beyond what you?
Hell yes. Good morning, everybody.
Yeah.
I just came back from the, 100 night shift that I have to work, so I can
You're
return.
exaggerating. It's only 98 night shifts. Okay, so.
Anyways, so what's the latest and the greatest? So latest and the greatest, because, you know, collaborating with the ministry, the Ukrainian Ministry of Health and the WHO, every now and again proves more often than not to be like dealing with a woman in PMS. It changes their mind all the time and has different ideas every minute, depending on what you ask them. But the latest and the greatest is that we're finally starting a project on evacuating people out of Ukraine. They finally admitted that they need help and they're not handling things well. Our teams actually are very far east, working in hospitals and providing frontline medical care to the combat casualties. So that's a big step forward, because so far it was like we don't need any help. And we are expanding our operations and training. So if I may ask, if anybody of you knows someone who would be willing to volunteer their time as a TC3 instructor for however they can, that would be fantastic, because we definitely need those people. The TC3 training has been widely requested by many different organizations, not just military. So, so if you know of anybody who would be willing to help us out, that would be phenomenal.
So
and I am done here May 6th.
Before
I'm
that,
out of here.
I'll give you
To Ukraine.
let me give you an immediate answer to that. Two people, for example, from our group that would be very interested in helping you out on that end. One is our medical director in Cincinnati, Dustin Calhoun, and he's already made contact with me, and hopefully, I think he's talked to you as well.
I think yes, but he forgot that he didn't renew his passport, that he doesn't have a passport right now.
Bummer. Okay, well then, never mind. Right. And then the other person,
He's in the process thereof, but it's going to take a little
the
bit.
other thing is, just so you know, I'm going to get Matt Strelo and Richard Schwartz together within the next 24 hours, and they're going to come up with some things that will be TCCC, you know, relevant and maybe even translated and all those kinds of things. So we're working on those, just so you know. Okay.
By the way, money heals many things. Okay, so you can get a new passport in less than 24 hours if you're willing to pay for it.
Oh yeah, no, I'm just laughing because he sent us an email, literally sent us an email offering to help, and then it was like, oh shoot, I forgot I didn't renew my passport. So.
Yeah, exactly. Okay, well, we'll fix that. Okay, so sounds good. I bet you he's on top of that as well, so which is good. All right,
Totally.
But then I understand, you know, aren't you the chair of the POCUS committee? It's like pre-hospital.
Oh yes, but that's a story for a different time, because it's a really long story.
You're the committee at NEMSP. You're the chair of that committee. it's all relevant to something that's going to happen next week. So we'll leave it at that, right? So,
Of
how's that?
course. Of
Okay,
course,
good.
it's very relevant to that. We need to have a very relevant conversation on how to run ultrasound in EMS, and that it doesn't begin and end with doing a course and buying ultrasound devices.
So we'll have that, you do that with us. And if for some reason you do end up back here by June, which may not happen, I still would like to, we'll have you do that presentation sometime. That'd be fantastic. All right.
Awesome.
All right. Let's see now. Let's see if there's any, Mike, anything else? And I'm looking forward to seeing Liv, by the way. So it sounds fantastic.
Oh, she's looking forward to it. Thank you.
Mike, by the way, Peter, anything you want to comment on? Peter Antebi, since you're kind of the host du jour.
I know, just excited that Cash is coming here. And by the way, a week after that, we're going to be in Palm Beach County, where I am today, where we're going to be rolling out whole blood. So that's going to be exciting. And we've connected with the folks. You and I have connected with the folks at Tulane for the data collection aspect of whole blood. So that's exciting as well. That's just a report from Palm Beach.
Beautiful.
All right. Anything else, Peter, then, while you got John? Okay, otherwise I'll slip over to Angus Jamison, the state medical director of Florida. Might as well while we're here, so we have a nice continuity here. Angus, anything report from your end or anything we should know about?
Hey, Paul. Yeah, just pretty much progress on all the stuff we talked about before. And looking forward to coordinating the meetings in Fort Lauderdale between the First There, First Care conference and the state EMS meetings that are happening there. So I think we're going to have really good attendance. Looking forward to it.
Well, and so for the Eagles, just let you know, what we've been talking about is possibly the last couple hours or hour or so, if not more, of our meeting, Eagle Creek, on Wednesday afternoon. Maybe we'll get some of the state medical directors to come on over and join with us and have a collaborative conversation. They enjoyed it apparently last year, and so would like to do that again. And it's great to have someone like Angus coordinate it. The other thing is they will have their actual meeting on, I think, Thursday morning. So they'll miss the first part of our Eagles meeting, but hopefully they'll be there for Thursday afternoon and Friday afternoon. But just great to have additional medical directors there. That's what we really need there as well. So, okay. And you agree with that, right, Angus?
Yeah, of course. Thanks, Paul.
Yeah. Okay, good. No, thank you. So let me see where we're also, I was trying to see if there was anything else on my reports that I want to do. I don't see anybody else on that could give us particular reports from the organizations. Mike, why don't you tell us if there's anything new we should know about in up in Canada?
Everyone, a huge amount. We're like everyone else. Sorry, missing the first part of the meeting, but the COVID wave is hitting us pretty hard in a human resource standpoint, both in hospital and pre-hospital. So that's sort of a, sort of a thing that people are dealing with regards to that. Offload's still becoming an issue, and we're still working towards some of our so alternate pathways of destinations and patients heading to clinics versus to hospital and remaining at home and follow-ups and things. So all of those are in play just to see if we can help sort of take some offload off the system. Paxlovid, from a provincial standpoint, has been thrown into the pharmacies and available for those higher risk patients. So that's a new work in progress on how that works with regards to some of the managements and treatment options that are available. I think our provincial government thinks that that's a solution to some of these issues, which I guess is part of the puzzle, but not all of the puzzle. And other than that, I'm enjoying the warm weather here.
All right, good. Well, that's really terrific to hear that you're having warm weather there then. So, hey, Ray Fowler, just want to prepare you. I'm assigning you and Terry Valenzuela to develop a good, what do you call it, debate for our meeting as well. So now that we were talking about the meeting here before. And again, does anybody have any problems either registering for or signing up or letting us know, what nights you need the hotel for and all that? Is that all going pretty smooth on that end? Anybody have a problem?
Yeah, Peter, John here. Could you resend a contact for registration for the Eagles members?
I just sent it to you, John.
Okay,
Yeah.
Thanks.
Send it to everybody.
Yeah.
Yeah, because Candace was supposed to have contacted.
Yeah.
Thought that went out. Did it not?
I didn't get it, or when like everybody else, I get about 300 emails a day.
Right. Okay. Okay, got it. Well, the other thing is she also said you can text her, call her. She's left a phone number too as well in the previous one. So, all right, if there's a problem, let me know and I'll try to forward those to her as well. Okay, let's see. Now that we got Josh Gaither on, so Josh, how's everything going as far as, did you guys get in a lot of good information for next year's meeting at AMSP? Josh has been the head of the program committee. So I just wanted to, just out of curiosity, since we're talking about the meeting, I just wanted to see if, one, are you coming? Number two, how that was panning out.
Yeah, no, hopefully I'll be able to make it to Florida. Looking forward to that. On the NAMSP conference side, we've got a lot of really good submissions. Normally, I should say last year we had about 115. This year we had 180 some. So a huge number of submissions, really great topics. Reviewers are reviewing them. So hopefully we're going to have an exciting program for Tampa in 2023.
So that was what I was going to ask you next. Let everybody know it's going to be Tampa. And what are the dates? Because it's an odd date. It's a little bit different than usual.
Yeah, it's the third week in January. It is, I got to pull it up so I don't give you the wrong week.
Usually it's the second week, if not the first week. Yeah, and move back more to the third or fourth week of the month.
Yeah, I don't remember off the top of my head. It is later than normal though. So I'll update y'all with the actual dates when I check my calendar next time.
Josh, I have it here on my calendar for the 23rd to the 28th. Monday through Saturday.
It was at the end of the month this time. Yes, exactly. Yep. So, well, good. And in Tampa, and it's gonna be held, I think, at the, if I remember correctly, at the Marriott there at the down at the wharf area there. So
correct. JP Marriott.
JW Marriott. That's
JW,
what it is. Yeah, right. Okay, good. So between us, we'll finally get it together. So that's good. All right, now let's see. Let's move on. If I'm just going down the list. Ben, anything happening in Milwaukee?
Yeah. Hey, Paul. No, things are pretty stable here. Doing our guideline updates, working on some department transitions, but overall going well.
Okay, thank you. Anything to report from across the board in Chuck Burnell across Acadian? Nope. Did I lose you, Chuck? You may have plugged out somewhere else. Okay, I'll skip over him. Joe Holly, you're next to my list, that kind of thing. I'm going to go back to you later, George, since we had heard from you last week. But Joe Holly.
Hey, good morning, Paul. Nothing terribly exciting going on here. Numbers are creeping up a little, but overall, nothing too dramatic.
Yeah. Hey, are you involved at all? I know they were going to have some kind of cadaver lab during their first care, but that's being held by someone else. You're not involved with that, correct?
That is correct. I think that's Marv Wayne and those guys doing that one.
Who is that?
Marvin Wayne from up near San Francisco somewhere. I think he's doing that one.
All right, got it.
He's from Bellingham. He's north of us.
Okay, got it. I'm going to find out what that's about then. That'll be interesting. All right, so let's see. Next, John Kramer, what can you tell us? Anything new from your end?
Not really, Paul. I was going to catch up with Gam the other day and wasn't able to. So really nothing to add right now.
Yeah, unlike you, he had been participating, so I'm glad to at least if you can reach out and find out what's going on, anything we should know about. You keep your finger at the pulse. So I think that's fantastic. So
you got it.
You got it. Yeah, right. For you, retirement is not being pulseless, right? But you are enjoying it a lot, so that's really good. All right, so Josh, Kasha, I talked to her. Libby, we talked to Mark. Anything else to report to Mark? Mark Gautreaux, sorry. Anything else new to know about?
No, actually, everything going well here. We just had a huge Home Depot fire Saturday that went to 5 alarms, nearly took out a neighborhood. But you can find the audio on YouTube, and it's pretty much a study in how to effectively manage a fire. It was really well done.
Okay. If you have something you can put in the chat and send to us, let us know. That'd be kind of cool. Sure. So, and by the way, you overheard me talking about working with Matt Strela. He turned out to be really a big guy. Tell him
he's a great guy.
Give him a pat in the back from me. Just
he's why I'm here.
Oh, really? Okay.
Yeah.
Good.
He's the one who recruited me here.
Was he out of Worcester originally or something like that?
Nope.
Or no?
Nope.
Okay.
He was just
Okay, he just knew talent when he sees it. Okay, got
pretty
it.
much.
All right, good. Well, thank you so much then, Mark. Let me see who was next on the list. Mark Escott, we talked to Mike Austin. Nick, anything you could tell us relevant or that we need to know about out of EMS world in the upcoming meeting?
Hello, EMS world, we've pretty much got things locked down. You can see the full schedule now is available online. We're really looking forward to seeing you all there.
Okay, good.
Right now, it's doing pretty good. We're getting ready for the Eagles. That's what we're working on right now.
Okay, good. All right, good. We're looking forward to seeing you there then. Fantastic. All right, Mark, Mike, let's see, Peter. Peter, we talked already. Okay.
I have a quick question.
Yeah, go ahead.
Just a real quick, because Mike Austin and I had a good conversation, and then I got another phone call from somewhere else in the country where people are wondering if there's any pediatric emergency medicine folks who did peds PEM, who are then going into an EMS fellowship. And I'm just trying to connect the dots there. So if anyone on the call has
Yes.
PEM, then
Not me. We have one of my co-fellows at WashU, Joe Finney.
okay.
He is PEDS, PEM, and EMS. So he's
Okay,
finishing his PEM and EMS in a combined fellowship. Mhm.
The reason I asked the question is because it comes up that in the from the regulatory standpoint, you know, a PEM person taking phone calls, these EMS calls that we get when we're on call, how to kind of place those people in safely and effectively. You know, Mike Austin had some great ideas, but I'll keep that in mind. And anyone else?
He does. So he has during fellowship, he has, it's been sometimes, challenging, he said, but he has taken medical control calls during the fellowship. So I think you can definitely talk all about his experiences.
Awesome. Thanks, Kasia. I appreciate it.
Do you want me to make the connection?
Please.
We'll send an
Thank
email.
you. Okay.
Okay, and then Scott Gilmore, since you're the medical director out in St. Louis, any comments on that? Sorry to catch you off guard, Scott.
No comments whatsoever.
Okay.
Yeah, we made with
No
we
comment.
met with Scott, but we don't take call. We don't take medical control call for St. Louis. So we a number of agencies. So that's why there wouldn't be any comment because there wasn't any cross
Got it.
activity. Let's
Okay,
call it
got
that
it.
way.
All right, got it.
No fires.
Hey, but Scott,
Looks like Rob in Columbus is doing it too. So thanks, Rob.
yeah. And then I'm going to come to Rob in just a second, but Scott, anything you report of or anything we need to know about for the meeting or anything you can tell us from St. Louis?
Really no update from St. Louis, pretty much same as everybody else. And if anybody has any problems or needs anything, please reach out to me and I'll try to get everybody taken care of.
Okay, good. You're the best. He's my behind the scenes hero, just getting this meeting going. So thank you so much. You don't get enough credit, Scott. It's fantastic having you on board and partnering with us. All right. Let me then go to Rob Lowe. And Rob, I need to tell you, I was covering a what do you call it here? A festival here on the beach over this weekend. And so we had these two nice ladies come up to us. I was dressed as a firefighter and we were on one of our carts there. And they turned out they were from Columbus and from State University Hospital. And they had too much blood in their alcohol system. They were actually able to talk to us. And so one of the persons knows you and will be saying hi. I just wanted to give you the context when they said, do you know Dr. Pepe, right? So
excellent.
They were delightful, though. Actually, they were nice. It just everybody was having a good time. There were actually some people listening to the music. It was kind of my sarcasm about the event, but it went really well, better than we thought it was going to go. All right. So, hey, anything to report from Columbus?
Fairly status quo. And Peter, I'd be interested in what you guys kind of come up with because our PIM fellow will actually start in July. And until you brought that up, it kind of hadn't crossed my mind. I can throw one question out to the group. So we recently did a little QI project here and curious on how many of you guys allow glucose per IO and what sort of policy you have around that. So stumbled on a case that I didn't expect recently. We have a decent number in cardiac arrest, but it's the non-cardiac arrest that I was worried about. So
And are you talking about children or adults or both?
It tends to happen more in adults for us, more than I thought.
All right. Peter, any?
So,
insight? Yeah, go ahead. Okay, John, that's a good point. John Jew, go ahead. Yes.
Yeah, sorry, Rob, a quick answer. We allow D10 only, IO. We do not allow D50 for obvious reasons.
Right. Yeah. That's if you can get it too, right? So anyway, so that's a good point.
Yeah, we also do. We've switched all to D10, and we do allow it through the IO, and we allow them to remove the IO and leave the scene.
Oh, interesting then. Okay. All righty. Well, then let's see. Who else did I have here? I'm just rambling around. Anything else though, Rob, to say and that you can bring up? One thing we've done in the past when we had PEM fellows is that having them, we actually would have either an attending or a regular EMS fellow to sort of do it in concert and as a backup. So if that was when it was convenient, so that way they got the experience. So just a thought, just to throw it out. It's a little time consuming, but if you make it happen, it can happen. So or you can work it out. All right. Let's see. Hey, Veer, got to jump down to you. How long is your tenure there, Veer? What's going on there?
So I'm actually physically leaving in June. I'm going to be staying on until we do a transition. So we did post the position. It's open and available for those of you who know people who might be interested. Tell them to have a look and apply. But so, we anticipate it'll probably take closer to the end of the year. So you'll still see me. I won't be able to make it to the conference this year because I'll be moving, but I'll still be on the calls and happy to help where I can.
Going to California. So, okay. So good. We're really excited for you. Disappointed for us, but but thank you for being around here today. Anything you'd report to for Fort Worth?
No, our BLS work continues. It's out of pilot phase now. So we've got summary results and things are going well. So our board approved that. We just crossed our 1 year of doing ET3 and that's also going fairly well. So yeah, good stuff all around.
Okay, very good. Trying to see if there's anybody I missed here. Sean, come on. Yeah, out there in Honolulu. Anything else to report beyond what we heard from Libby?
Good morning, Paul. Nothing else to report with the exception that we successfully did a half marathon. And so we're actually planning for the full Honolulu Marathon, and we expect to have like a large contingent. We expect at least 50,000 people towards the end of the year. So since we were able to do the half marathon successfully without any big spike in cases and without any other incidental findings, that's kind of the biggest thing on our radar. And as an aside, we have a lot of administrative changes because Honolulu EMS prior has been a state function, and in July we're going to become a city department. So it's a lot of beehive activity with that now, but otherwise nothing else to report.
Beehive, pure honey. Okay, sounds great. We'll see how that turns out, right? It'll be exciting for you. Well, good. It's great to hear from you. Sean, do you remember how do we handle the PEM fellows? Did you remember what we did back in the day when you were with us?
I don't remember that there was no like dual certification back then at Parkland, and I know we had one, but I don't remember if we did anything in particular with them besides vote them in. But I know there wasn't anything codified, and maybe Ray might have something like have a better take on it, but I don't remember anything specific.
He had to go because he had an EMS run. So anyway, so I would ask him. We'll follow up with that later. All right, so Veer, Terry, anything to tell us from Tucson outside of what we heard from Josh today?
No.
Okay, good. I love it because you're very copious of you, right? Just get to the point and that's it. All right, Terry, we're looking forward to seeing you in the great state of Florida. Do you have all your visas and vaccinations already? Coming.
I have a green card. I thought that would be most important.
That's what I figured. That's great. And it does, and your name will be spelt out in great detail, your birth name, right? So
yes.
All right. The bad joke between us, right? So, all right, but good. Thanks a lot, Terry. I'm looking forward to seeing you. All right, Scott, Rob, Roger, anything to report on Montgomery County since you're on visiting with us past here? Yeah.
Sure. Thanks. I'm always honored to be able to listen in for the last several meetings. We're, one of the goings on here that's only literally a couple hours old is the release of a clinical practice guideline locally, which is allowable within the statewide Maryland protocols, that is making the big leap to a strategy in out-of-hospital cardiac arrest, airway management, to one endotracheal tube attempt 1 minute, and then go to a supraglottic if unsuccessful. One of the inspirations was the literature source by Jeff Jarvis. He had released a video that's about an hour long, plus the 3 clinical trials that have taken place since 2018. And we know that it's a big pill to swallow for paramedics to be told they have one shot, and if they can't, just go to a supraglottic. But that's where the science is, and so we're in the process of socializing that in our system. We have one other large metropolitan system in suburban Baltimore that's going to be doing the same thing, and even Dr. Jarvis in Williamson County has said that he's still at 2 is your maximum before going to a supraglottic, but he's contemplating doing the same thing. So that's kind of big news where we are. And I know, and one other thing that came out of the discussion is that Maryland as a state does not have any caps on the number of attempts. And it's making Dr. Chismar think about the fact that maybe the state should be looking at that. So that's the big news, and it's literally a couple hours old where we released our guidelines. And we also did a podcast locally where Henry Wang came to discuss the PART tribe that he was the PI on, and to try and get our folks socialized on why we're doing this. So that's the big news.
Okay, thanks so much. Hey, Dr. Hatch, anything to relate to us other than what you said last week? Anything new on your end?
No, Paul. We do have a conference, our accreditation conference. We had a big splash in 2019. Pandemic hit in 2020, so we didn't have it at all. We did a virtual offering last year, so we're back face to face this year, and we have a very distinguished keynote speaker. Peter is going to be opening up the conference there. We've got about 350 people registered. It's not just for program directors, their lead faculty or clinical coordinators, but also for the physician medical directors of those educational programs, as well as deans, presidents, VPs of instruction, and state OEMS offices. So if anyone's interested, we'd love to have you.
Where is that and when is it?
That will be in Louisville, Kentucky. It is the week following or the week of Memorial Day. So it actually starts Wednesday with a pre-con and then ends on Sunday morning at noon.
That's great that you calling Peter distinguished. I really like that. So as opposed to some of our other friends who are extinguished. So
very good.
Thank you so much for that report. Let's see. Anything that you could tell us, AJ Heitman? AJ, anything from your end? If not, then let me go back and try Chuck once more. Chuck Burnell, anything you could tell us?
Hey, Pepe, can you hear me okay?
Yes, I can, sir.
Oh, things going well on our end. We successfully opened up in Nashville in Corey's backyard a little while back. That's going well. Besides, the usual fight staffing and drug short supply and stuff, not a lot new going on except festival season in New Orleans. So we're busy with that right now.
Okay. I will say that in terms of drug shortages, there's apparently no drug shortages in Washington, D.C. Rob Holman basically has been at a press conference just over the last hour or so with mayor and all that. They've had an enormous number of drug overdoses over the last, I would say, 50, 60 hours. It's been significant. So there must have been a batch that came in and they had a lot of bad cases. He's going to probably come back and report it to us next week, et cetera. And other than that, I don't think I missed anybody. I think we've.
Well, I'm back here. I'm sorry, I stepped away.
Yeah. Anything to report to us? We got 2 more minutes. 120.
Well, we have a big trauma supplement coming out digitally from EMS World June 1st on occult trauma.
Okay.
And I'm also working on a big after action report on the Interstate 81 MCI and the snow squall.
Okay. Now, when you say occult trauma, in other words, subtle things either in kids or other adults, or what are you thinking? Like
we're talking hidden trauma. We're talking flail chest, other things where you can't see any bleeding.
I got it. Yes. So it is a
And,
trauma case. It's a clear trauma case, but some of the subtle findings that you don't want to miss. Okay.
Yeah, particularly pelvic injuries. We're going to have video clips of cadavers showing infusion of fluid and flail chest, et cetera. It's going to be pretty amazing.
Yeah. Okay. Got it. All right. Well, sounds good. Thank you so much for giving us the heads up on that. Looking forward to it. Anybody else want to say anything else before we get off and part our ways till next Tuesday? I'm trying to remember where I'll be next Tuesday.
Oh, quick
Yeah.
announcement from Austin.
Yes.
We've hired our 4th EMS physician full-time, and we've stolen Andrew Cho from Dallas. So apologies to Marshall.
Fantastic. Yeah, good plan then. So that's good for you. And how are things? Have you rolled out your what's that called? The thing that Mark Eckstein's program with the E911, whatever it is. Yeah.
The telehealth is still a work in progress.
Okay, got it. All right. Got it. Just curious then. All right, we'll talk later. Hey, so listen, thank you so much then for everything, and appreciate everybody's time. See you back next week. Welcome back, my friends. The show that never ends next Tuesday. And I think I'll be sitting right in the same spot, hopefully next week as well. Okay. So thank you so much, everyone. Take care and have a great day.
Bye.
And a great week. You're going to have a great week next week. Yeah. So, oh, that's right, Kasha. I'm going to be reporting from I'll be reporting from the West Palm Beach Hotel. That's what it'll be. All right. I'll see you later then. Take care.
Thanks, Paul.